So you're back for more, huh? I guess some people just can't learn. Welcome to another Persiflager's podcast to review the infectious disease literature with commentary for the last 2 weeks of January 2007. For those who are sick unto death of this intro, skip ahead to the next chapter using your super-duper iPod. Brought to you by Puscast LLC, publisher of the Persiflager's Annotated Compendium of Infectious Disease, Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at Pusware.com. Legalese. All the opinions are those of Mark Crislip and Pusware LLC, and not those of Legacy Health System, its employees, the IDSA, the IDSO, the AMA, or anybody with more brains than God gave a goose. Now CME accredited. Listen, take the online quiz and get a half an hour of free CME. Thank you, Legacy Health Systems. Also, to mention any potential conflicts of interest, I have not talked to a drug rep nor accepted anything from a drug company in over 18 years, so the biases are my own. No freelunch.org for details. Not that my honor and integrity are not for sale. They are. I just can't find a buyer. The purpose of this podcast is to review the literature of the last several weeks and, with commentary, to claim and pontificate on those articles that are of interest to me and hopefully to you. It is not a comprehensive review. I want to get to the point, so I favor breadth over depth and cheap shots over seriousness. Keeping up in medicine is like drinking from a fire hydrant, to quote Dr. Richard Bryant. This is my sip and is aimed at the practicing healthcare professional and the occasional psychotic amateur. I am, if you're interested, a practicing infectious disease doc in Portland, Oregon. I do this to teach my residents, to help out our program. If you want to become an internist, try legacyhealth.org. Help me learn, and most importantly, to advertise the aforementioned guide. But, as Gag Hellfront said of another, I'm just this guy, you know? As a warning, it's not called Persiflagers for nothing. This podcast may contain snide comments, sarcastic asides, and short rants on political or other contemporary issues. Don't complain and whine. I didn't warn you in advance. Also, I have been called an arrogant subspecialist who does not appreciate the limitations of primary care. Ha! That's me. If you like this sort of nonsense, check out my Quackcast at quackcast.com. Also available on iTunes. A review of alternative and complementary medicine with sarcastic asides. Also, the references are all online, including some not mentioned in this podcast. Now, on to the literature. First up is HIV, and a study that was published in the Archives of Internal Medicine that looked at selenium supplementation in HIV patients. They took patients on heart and they were randomized to either receive 200 milligrams of inactivated yeast or 200 milligrams a day of high selenium yeast. Evidently, selenium is best applied as in yeast as Selenomax, and this is a bioavailable form of selenium. You're not supposed to drink your dandruff shampoo. Over time, patients increase their selenium levels, but what's interesting is that patients in the placebo group, i.e. those without selenium, had an increase in their viral load by about 10,000 copies per mil. Those who responded to the selenium also had an increase in their CD4 counts as well as maintained their viral load. So it would appear in this study that was published in the archives that selenium supplementation is a good way to help get synergy with your HIV medications to keep your viral load stable and your CD4 counts up. This would especially be true if you were selenium deficient, not a standard test to order. And at least based on this study, I would just jump straight ahead to selenium supplementation. They warn in this article that not all forms of selenium have the same bioavailability and that many of the preparations out there have selenium that cannot be absorbed. So perhaps you would want to use the brand that was used in the archive study. So you have a 25-year-old patient showing up in your clinic with new diagnosis of HIV, and they want to know, Doc, how long do I have to live? Well, I'm not psychic unlike Sylvia Brown, so I can't predict the future, but the Annals of Internal Medicine can. And this article out of Denmark looked at survival on population basis of patients with HIV who receive HAART and compared them to normal controls. They estimate that if an HIV patient age 25 gets on HAART, that they will have a 35-year life expectancy with their HIV compared to normal controls without HIV. This applies if they don't have hepatitis C. What's very striking is the graphs in this article on survival in Kaplan-Meier curves over the years with HIV medications and AIDS, and the really dramatic effect that this medicine has on life expectancy. I think you can safely tell your patients that when they have HIV disease, that it is not an imminently fatal disease, and that current studies suggest that they at least have 35 years, and I would bet longer, given the current advances in this disease. What do you do with mononegative exudative pharyngitis, since a monospot is not the world's greatest test? You check a CBC. How will that help you? Well, lots of atypical lymphs will make you think of infectious mono, but also, as published in the Archives of Otolaryngology and Head and Neck Surgery, which is a mouthful right there, you can do a ratio between the lymphocyte count and the white count, and if it's greater than 35, that had 100% specificity and 90% sensitivity for infectious mono. So what happens in the mononucleosis group, they tend to have a higher amount of lymphocytes versus those who have bacterial, and a lower white cell count versus bacterial. So you have fewer white cells, more of which are lymphocytes, in patients who have infectious mononucleosis. Divide the lymphocytes by the white cells, and if you get a ratio of 0.35 or greater, you got mono. Relatively simple test. Association is not necessarily causality, but a study that looked at the risks for the development of Epstein-Barr positive lymphoma found that patients who are active smokers had a much higher risk, 1.7 odds ratio, of developing an Epstein-Barr positive Hodgkin's lymphoma versus non-smokers, and that this risk maintained for up to 10 years after stopping smoking. So yet another cancer that's certainly associated with the use of tobacco. Fortunately, this study found no association with the development of Epstein-Barr positive Hodgkin's and alcohol consumption, so you can safely have the beer tonight. Just stay away from the Camel cigarette. Or the Camel, for that matter. And as long as we're on the topic of herpes virus, there was just a case report and review of the literature on portal vein thrombosis associated with acute CMV. One of those clinical associations I was unaware of, so now we both are. Bird flu, or avian influenza, continues to wander around the world. It's now in Egypt, and there have been a total of 161 deaths due to 267 cases. Not a big deal yet in terms of overall global health. However, there were 2 patients who died in Egypt of avian influenza, and their strain had moderate resistance to oseltamivir, i.e. Tamiflu. This was first detected in 2005 in Vietnam, but it did not spread beyond Southeast Asia. Now it's in Egypt. Not a big surprise, as there are various strains of this organism that have variable susceptibilities to oseltamivir, and one would expect that widespread use of oseltamivir will rapidly lead to resistant organisms. The original article on this was on the origin of species by some guy named Darwin, I think. But the Borg got it wrong. Resistance is not futile. Resistance is inevitable. Now, I'm an adult infectious disease doctor. I do not take care of children, and I rarely take care of any children except my own. But I will note in passing, the New England Journal of Medicine this month had an article on tympanostomy tubes in children, and they looked at whether or not putting prompt tympanostomy tubes had any effect on cognitive, hearing, or developmental changes in children, and they found it didn't do diddly squat. They concluded that young children with persistent middle ear effusions, prompt insertion of tympanostomy tubes does not improve developmental outcomes up to 9 to 11 years old. So basically, putting tubes in the ears in normal kids with asymptomatic effusions is not warranted. I mention this because this is the sort of thing you may get asked in passing by friends and family, even if you have no particular area of expertise in infectious diseases or in pediatrics. So rather than tympanostomy tubes, I think you should buy your kid an iPod and have him listen to my podcasts instead. And now a whole hodgepodge of things about my favorite pathogen, Staphylococcus aureus. The first is a study out of Europe that looked at Staph aureus bacteremias and what happened in 2006. They looked at 350 Staph aureus strains from bloodstream infections in 32 hospitals in France. What they found was a big change in 2006 that after regularly declining incidence of disease, it markedly increased by 80%. They had two types of Staph aureus causing their bloodstream infections, the most important of which was an MRSA that was also quinolone resistant. And they hypothesized that the use of quinolones is contributing to the acquisition of MRSA and toxic shock toxin genes, and that this new strain is being seen with increased frequency in France. Certainly in Portland and the United States, methicillin-resistant staph is markedly increasing, although here in Portland it's not resistant to just methicillin and fluoroquinolones, but to all antibiotics except for doxycycline and Bactrim. So depending on where you are, you may be seeing a different pattern of MRSA outbreaks depending on your local antibiotic use. Now, I've said many times before that one of the surest way that you know that someone doesn't know a burrow from a burrow for infectious diseases is if they use the term strong or powerful when it comes to antibiotics. Frequently, people who know nothing refer to vancomycin as a strong or powerful antibiotic. One of the advantages of vancomycin is its ease of use in dialysis patients, and you can dose it about once every 5 days because it is not dialyzed off. Now, this interesting study looked at the use of vancomycin or cefazolin in patients who developed MSSA bacteremia. So what happened is a dialysis patient came in, they think they have staph in their blood, they get started on vancomycin. Some patients continued on vancomycin, others were changed to cefazolin. And guess what? Those on vancomycin did worse. They were at higher risk for developing complications and failure as a result of being treated with vancomycin for their methicillin-susceptible Staph aureus. Vancomycin is a crappy drug. Always has been, always will be. And do not substitute good drugs for convenient drugs in your dialysis patient. That is definitely the take-home message of this study. Certainly the good outcomes with cefazolin was nice to see, as cefazolin is dosed once a day in a dialysis patient, and the downside of methicillin or nafcillin is you have to give it every 4 hours. So at least the benefit here is that the beta-lactam is superior to the vancomycin, and that a once-a-day drug such as cefazolin is superior to vancomycin and more convenient than the anti-staphylococcal penicillins. I remain conflicted about what to do with patients who are colonized with MRSA. In the outpatient setting, certainly, if they're having recurrent abscesses, it's worth an attempt at decolonization. But what to do with hospitalized patients? Studies have indicated that patients who are newly colonized with MRSA are at high likelihood of developing invasive disease, and they may be a source for future outbreaks in your hospital, although given that we are awash in MRSA in Portland, I'm not so certain that's true. There was a study in this week's CID that looked at decolonization of patients and found that it was effective in removing MRSA colonization in patients up to 3 months of follow-up. They treated patients with a combination of chlorhexidine washes, intranasal mupirocin, and rifampin and doxycycline for only 7 days, and found that patients who received this therapy remained MRSA on multiple cultures up to 3 months about 74% of the time, and those who received placebo became decolonized about 32% of the time. The interesting thing is that the natural history of this disease is for decolonization in about a third of patients, where the patients who received therapy, about 75% of them lost their MRSA. So it is a benefit. Now, this study did not look to see if this was associated with a decrease of staph in their environment, nor did they see if patients had decrease in disease. But certainly if you're thinking of having a hunt and destroy of your MRSA and you're looking for patients who are colonized, chlorhexidine, mupirocin, and oral doxy and rifampin is a beneficial way to eradicate it in the majority of patients. Whether it's worth it or not, I still am skeptical. And it strongly depends upon your local environment. Here in Portland, Oregon, we lost the battle years ago. The manifestations of staph infections are due to toxins, and this organism produces too numerous to count toxins. Important toxins include the Panton-Valentine leukocidin, the toxic shock toxins, and the various homolysins made by this organism. In this in vitro study out of Seattle, they found that subinhibitory levels of methicillin increase the production of toxins in Staph aureus. Now, hopefully you're not dosing your patients with subinhibitory levels of antibiotics, but the important thing here is that clindamycin and linezolid both suppress the translation of toxin genes, not the transcription, but the translation. I have thought for a while that there's biologic plausibility in treating severe staph infections with clindamycin to decrease toxin production. Certainly for hemorrhagic pneumonias or other severe staph infection, that's a reasonable thing to do. The fact that methicillin may enhance toxin production and you may not have therapeutic levels for the first several doses in patients who are getting antibiotics suggests that with severe staph infections such as pneumonia, it may be of benefit to give patients both clindamycin and a beta-lactam or linezolid and a beta-lactam to prevent toxin production. Now, I want to emphasize this has not been demonstrated in clinical trials yet, but when you have severely ill patients, I think it's reasonable to take studies such as this and use biologic plausibility as an argument. Unfortunately, here in the Northwest, we have lots of clindamycin resistance and inducible resistance in our Staph aureus. I'm not certain that it's the right choice over linezolid in this group of patients. The take-home message of this in vitro study is that severe staph infections may be treated with a beta-lactam or vancomycin plus either clindamycin or linezolid. Though I'm not certain that I would for endocarditis, I may for severe necrotizing soft tissue infections and staph pneumonia. Recently there was a JID article where they used Panton-Valentine leukocidin knockout staph and compared their virulence and found them the same in an animal model as organisms that made Panton-Valentine leukocidin. This is to be contrasted with a recent article in Science where they injected Panton-Valentine leukocidin toxin directly into the lungs of mice and found that it caused a hemorrhagic pneumonia. I remain unconvinced by the article with the knockout strains of staph about the lack of virulence of Panton-Valentine leukocidin. I think the vast majority of the data suggests it's an important virulence factor, and if you can mess with it by giving clindamycin or linezolid, that may be of great benefit to your patient. ID doctors, of course, love synergy studies. Whether they have any applicability in human beings is always uncertain, but a recent study looked at synergy with daptomycin, one of the newer anti-staphylococcal agents. The take-home message was that they found in vitro synergy between daptomycin and gentamicin in about 68% of strains, but found virtually no synergy between daptomycin and rifampin. So while rifampin is popular with drugs such as Bactrim, doxycycline, and vancomycin, rifampin should probably be avoided because it doesn't do anything if you use linezolid and now daptomycin. But you got to give double coverage. Double coverage is important. Give double coverage. Double coverage. Yeah, forget about it. As long as we're on the topic of gram-positive antibiotics, let's mention vancomycin briefly in a study that was published in Clinics of Infectious Diseases that looked at the levels of vancomycin in CSF who had pneumococcal meningitis. The good news is the use of steroids did not have the effect of decreasing vancomycin levels in the spinal fluid as long as you gave enough vancomycin. In this study, they found that with a mean level of vancomycin in the serum of 25 micrograms per mil, they found the CSF level to be 7 micrograms per mil, which is more than enough to kill off a pneumococcus. The important thing, however, is you really got to give vancomycin up front. In this study, they gave a continuous infusion of 60 milligrams per kilogram of body weight per day after a loading dose of 15 milligrams per kilogram. So they really gave a whopping dose of vancomycin and found that their CSF levels under these conditions were sufficient to get rid of the pneumococcus. Whew. And normally I don't give my vancomycin in a constant infusion, but it's something to consider in a case of meningitis if you're worried about pneumococcal resistance in the spinal fluid. Bacterial vaginosis is a disease of great annoyance to women, but when you're pregnant, it's even worse than that. This is a study out of Denmark that looked at 3,200 pregnant women and found that 16% of them had bacterial vaginosis. The mean effect of this was that they had decreased birth weights by about 100 grams. They also had increased preterm delivery, increased chorioamnionitis, so that having bacterial vaginosis is a bad thing if you happen to get pregnant as well. How then to treat it? Well, a study published in CID suggested that treatment with azithromycin in addition to metronidazole was not of benefit. They found that 7 days of therapy had better short-term effects than 14 days of therapy, but by 21 days after stopping the use of therapy, both the 7-day group of metronidazole and the 14-day group of metronidazole had the same cure rates. Things that were most associated with getting a cure of bacterial vaginosis was combining therapy with the consistent use of condoms and to refrain from douching. It is perhaps whether they were reinfected or relapsed is still uncertain, and still at question is whether or not treating your sexual partner it would be of benefit with the prevention of BV. You know, the motto is use it and lose it. In prior podcasts, I've discussed how the prior use of macrolides is associated with Helicobacter pylori macrolide resistance. Guess what? If you treat a patient with a fluoroquinolone in the prior 10 years, then your chance of having a H. pylori resistant to a fluoroquinolone is about 10%. So if you've had exposure to quinolones of any type in the prior decade, your chance of having a quinolone-resistant H. pylori is about 8.8%. It's amazing how little exposure can lead to significant resistance in bacteria. What to do about recurrent C. diff is always a problem. If they fail Flagyl, you switch them to Vanco. If they fail Vanco, you switch them to Flagyl. But what do you do if they fail both? In a study published in the gastrointestinal meetings, they looked at the use of rifaximin, 400 milligrams TID, for 10 to 14 days and found that in the majority of patients, they prevented a relapse of C. difficile. They also had a study where they treated C. diff with this agent and had good outcomes, with only one organism being resistant to the rifaximin. I think this is interesting, and the issue of what to do about relapsing C. difficile is a headache. I've often given long tapers of either vancomycin or metronidazole, but perhaps the drug to use is the rifaximin 400 TID for refractory or relapsing C. difficile diarrhea. Remembering that this is not a published study yet, but only presented at the meetings. There's Legionnaire's disease, which everybody knows is an atypical pneumonia, probably underdiagnosed, but it can also cause Pontiac fever, which causes a, quote, flu, unquote, like illness, fevers, myalgia, and not feeling well, often associated with outbreaks and often associated with water exposure, such as hot tubs, etc. There was an outbreak in Oklahoma of Pontiac fever of over 100 patients, and it was mostly associated with using the hot tub. Now, the nice thing is that the urine antigen was not bad for diagnosing Pontiac fever. They used the urine antigen and serologies on these 101 patients, and they found that the sensitivity for the urine antigen was 35.7% and 50% for the serologic testing. The specificity was 100% for the urine antigen. So, that's not bad. And if you're worried about an outbreak of a febrile flu-like illness associated with swimming pools, hot tubs, saunas, etc., think of doing a urine antigen and serology for legionellosis. You have a monoarticular acute arthritis, crystalline disease, septic joint. Is one or the other, right? Well, maybe not, because there was an article that looked at the presence of both diseases and found that about 1.5% of times Patients who have crystals in their joint will also have an infected joint. So that's not many. That's 4 cases out of 265 joint aspirates. How can you tell the difference clinically? Well, the synovial fluid white counts were markedly higher in patients that had both. Greater than 50,000 was the cutoff. And they found that the mean synovial white count in patients who had crystals and aseptic arthritis was 113,000. So, if you tap a joint and you see crystals, but you have 100,000 white cells in it, you may also have a concomitant bacterial process in that joint as well. Occam's razor may not apply. There's nothing better in life than a clinical study that proves something that you thought was true beforehand. In this case, the question is, what do you do with MRIs in patients who have spinal epidural abscesses, discitis, or osteomyelitis? Is it of benefit to repeat the MRs? And the answer is no. That the changes that you see on an MRI can persist up to 6 months after a discitis or vertebral osteomyelitis, and that the changes are not associated with pain, relapse, or poor response to antibiotics. So if you have someone with a pyogenic spondylodiscitis and they're responding clinically with decreasing pain, SED rates, etc., repeating an MRI is a waste of time. This was published in the journal I Told You So, otherwise known as Rheumatology, this month. The next 2 papers are probably going to cause your pharmacist some chest pain, because I'm sure when this drug is released it's going to be very expensive. The drug in question is posaconazole, and there are 2 studies this month in the New England Journal of Medicine using this drug as prophylaxis. The first study compared oral posaconazole with oral fluconazole for prophylaxis in patients who have immunosuppressive therapy with graft versus host disease. And they found that posaconazole was superior to fluconazole at preventing invasive aspergillus, and it reduced the number of deaths related to fungal infections. The second study was also published in the same issue of the New England Journal of Medicine, and this one compared posaconazole versus fluconazole or itraconazole in patients with neutropenia secondary to treatment for AML or myelodysplastic syndrome. Posaconazole was better. It caused fewer deaths, and it resulted in fewer invasive fungal infections. Now we need a head-to-head coverage between posaconazole or voriconazole so that we know who the world champion is for the prevention of fungal infections in neutropenic patients. Voriconazole does have the disadvantage that it is not as active against mucor as posaconazole. However, I think it's down to one agent or the other right now for the prophylaxis of neutropenic febriles, and that fluconazole and itraconazole are fading into the past. This, I'm sure, for transplant centers will result in a marked increase in the antibiotic formulary costs for the purchase of antifungals. This last one is concerning Mycobacterium tuberculosis and may be of more interest to you ID types out there. It's long been said that when you're treating patients with tuberculosis that there's a biphasic decrease in the number of organisms, and that the first part is mediated by INH and allegedly due to the fact that you rapidly get rid of the exponentially growing organisms that INH is effective against. The second phase of clearance of AFB is mediated by rifampin and pyrazinamide, which is slower and occurs when you have a lower bacterial density. This was put to the test by Mythbusters, now the Clinics of Infectious Diseases, and they found that it was actually due to INH resistance that led to the marked decrease in the efficacy of INH in the initial clearance of tuberculosis due to anti-tuberculous therapy. And that's it. I would point you to 2 reviews, one on the importance of antibiotic stewardship and the other on the role of microbial agents in Crohn's disease, both of which are published in Clinical Infectious Diseases this month, but being review articles are not germane to the point of this podcast. And then finally, I was very surprised by this. A study that looked at drug ads on television and found that they played to people's emotions rather than their intellect to sell their drugs. I'm shocked about that. Shocked, I tell you, to find gambling going on in this establishment. Well, anyway, that's the end of the Persiflagers podcast for January 15th through 31st, 2007. A review of the infectious disease literature with commentary. References, including some not mentioned in the podcast, are available on the website. CME accredited. Now that you've listened to this drivel, take the online quiz and get a half an hour of free CME. Free! Can't beat a better price than that. Brought to you by Pusware LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Disease Facts, Opinion, and Dogma, your uber hyperlinked electronic guide to infectious diseases at pusware.com. If you like this sort of nonsense, check out my Quackcast, available on iTunes, where I review various aspects of scam. Supplements, complementary, and alternative medicines. Scams. That gives you my bias. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. It's copyright by the Creative Commons license, creativecommons.org. The music is my son when he was 12, improvising on the guitar. He's a way wicked guitar player now. For comments, feel free to email me at mcrislip@pusware.com. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.